Welcome to Evidence-Based Cardiology Talks. I'm your host.
And I'm our expert for today.
We're diving into the latest research that's really shaping how we think about contemporary cardiology.
That's right.
Today, we're looking at a really interesting study just published in the European Heart Journal. It tackles this question of what drives cardiovascular risk after a patient has had a PCI percutaneous coronary intervention, and importantly, they're already on statin therapy.
Yeah. A really common scenario we see.
And just a reminder, this discussion is all under the supervision of Dr. Caroli. You can find more at drcaroli.com.
So yeah, the background is, look, we all know lowering LDL cholesterol, the bad cholesterol, is absolutely crucial. We hammer that home all the time.
Right, cornerstone of prevention.
And we also know inflammation is a big player in cardiovascular disease generally. But what was sort of missing, or less clear, was the relative impact. In these specific patients, post-PCI on statins, if they still have issues, is it more about that leftover stubborn LDL cholesterol, or is it more about ongoing inflammation?
Which one is the bigger bad guy, essentially?
Exactly. That's what the study aimed to tease apart. Which one is predicting future problems, like heart attacks or strokes? It's super relevant for how we manage these folks long term.
Okay, so let's get into it. How do they actually investigate this? These are patients, arteries opened, on cholesterol meds. What was the setup?
Well, it was a retrospective study, meaning they looked back at patient records. Quite a large number, actually almost 15,500 patients.
Wow, okay.
Yeah, all had undergone PCI at Mount Sinai Hospital in New York sometime between 2012 and 2022. And crucially, all were documented as being on statin therapy.
Got it. So everyone's getting that baseline standard of care.
Right. Then, the researchers did something quite neat. They divided these patients into 4 distinct groups based on 2 measurements taken around the time of their PCI.
Okay, what were the measurements?
First, LDL cholesterol. They used the common target. Was it 70 milligrams per deciliter or higher, or was it below 70?
So above or below that key threshold. And the second?
The second was high-sensitivity C-reactive protein, or hs-CRP. That's our marker for inflammation.
Right, hs-CRP.
And the cutoff they used there was 2 milligrams per liter. So again, was it 2 or higher, indicating elevated inflammation, or below 2?
So crossing those 2 factors gives you 4 possibilities.
Exactly. You get Group 1, low LDL and low hs-CRP. Let's call them the no residual risk group.
Makes sense.
Group 2, high LDL but low hs-CRP, the residual cholesterol risk group.
Okay.
Group 3, low LDL but high hs-CRP, the residual inflammatory risk group.
The flip side.
And finally, Group 4, high LDL and high hs-CRP, the combined risk group.
Okay, that framework makes sense. But what about people with really sky-high inflammation from, say, an infection or something else acute? Do they account for that?
Good point. Yes, they tried to focus specifically on that sort of chronic low-grade cardiovascular inflammation, so they excluded patients who were having an acute MI right at the time of their PCI.
Okay.
They also excluded patients with active cancer and anyone who wasn't actually on a statin when they came into the hospital.
Right, need that baseline therapy.
And to your point about acute inflammation, they specifically excluded anyone whose hs-CRP was really high, over 10 milligl. The thinking was that level might suggest an acute infection or some other non-cardiovascular inflammatory process.
So they're trying to isolate the signal from cardiovascular inflammation. And what were they tracking? What was the outcome?
The main outcome, the primary endpoint, was major adverse cardiovascular events occurring within 1 year after the PCI procedure.
And MAN here was defined as?
In this study, MAN included death from any cause, a spontaneous heart attack, not procedure-related, or a stroke.
Okay, the classic heart endpoints. So before we get to the outcomes, what did these groups look like at the start? Any big differences in the kind of patients in each group?
Yeah, there were some interesting baseline differences. First off, it was quite striking that even though all these patients were on statins, more than 40% of them still had that elevated hs-CRP level, 2 or higher.
Wow, nearly half still had significant inflammation despite the statins.
Exactly. It shows you statins don't eliminate inflammation for everyone. Then, comparing the groups, the patients who only had the high inflammation risk tended to be a bit older.
Okay, age playing a role.
And interestingly, the group that had both high cholesterol and high inflammation, that group had the highest percentage of women.
Huh, that's interesting. Any link with other health problems?
Yes. Things like diabetes and chronic kidney disease, CKD, were definitely more common in the groups that had elevated hs-CRP, so both the inflammation-only group and the combined risk group.
That fits, right. We know inflammation is tied up with diabetes and kidney issues.
It certainly points in that direction. It suggests that inflammation might be part of a cluster of risk factors in these patients.
And how many patients ended up in each bucket? Was it an even split?
Not quite even, but reasonably distributed. The largest group, around 30%, was actually the no residual risk group, good control of both LDL and inflammation.
Okay, that's encouraging for some.
Then, about 28% had just the residual cholesterol risk. The smallest group, about 17%, had only the residual inflammatory risk.
Only 17% with just inflammation.
Yeah. And then the combined risk group, high on both counts, made up about 25%, so a quarter of the patients.
So quite a mix,
Yeah.
but a substantial number, well over half, still had either high cholesterol, high inflammation, or both, despite being on statins post-PCI.
That's the key takeaway from the baseline residual risk is common.
All right, let's get to the main event then, the one-year MACI outcomes.
Yeah.
What did they find? How did these groups fare?
So overall, across all 15,000 plus patients, there were 426 MACE-E events, deaths, MIs, or strokes within that first year.
Cool.
But the really striking finding, the headline really, came when they broke it down by those four groups. The group with the highest rate of NCE was...
Guess. The combined group.
Yeah.
High cholesterol, high inflammation.
That's what you might intuitively think, right? But actually, no. It was the group with isolated residual inflammatory risk.
You mean low cholesterol but high inflammation?
Exactly. Their LDL was less than 70, seemingly well controlled, but their hs-CRP was 2 or higher. That group had a MACE-E rate of 5.1%.
5.1%. Wow. Okay, how did that compare to the others?
Well, the combined risk group, high LDL and high hs-CRP, was next at 3.7%.
Still high, but lower than inflammation alone.
Right. Then came the group with no residual risk, low LDL, low hs-CRP. Their rate was 2.6%.
Okay, the reference group.
And perhaps most surprisingly, the group with only residual cholesterol risk, high LDL but low hs-CRP, actually had the lowest MCRP at just 2.3%.
Lower than the no-risk group, or just very similar?
Very similar, essentially the lowest. And importantly, the statistical tests showed these differences between the groups were highly significant. It wasn't just random variation.
That is quite counterintuitive based on how much we focus on LDL. Inflammation alone being worse than high LDL alone, and even worse than having both risks combined.
It certainly challenges some assumptions, but of course these are just the raw rates. The next crucial step is to account for those baseline differences we talked about, age, sex, diabetes, etc.
Right, because the groups weren't identical to start with. Did they do that kind of adjustment?
Absolutely. They performed multivariable Cox regression analysis. It's a statistical technique that lets you estimate the independent risk associated with each factor, like inflammation or cholesterol, while mathematically controlling for the influence of all those other baseline characteristics.
So isolating the effect of inflammation itself and cholesterol itself.
Precisely. And even after adjusting for age, sex, BMI, race, smoking, hypertension, diabetes, CKD, prior heart attacks, basically all the usual suspects.
What happened? Did the inflammation link hold up?
It absolutely did. The isolated residual inflammatory risk group still had a significantly higher risk of ME compared to the no residual risk group. Their adjusted hazard ratio was 1.78.
So almost an 80% higher risk, even after accounting for everything else.
Yes, a strong independent association. The combined risk group also remains significantly associated with higher ME risk, with an adjusted hazard ratio of 1.56.
Okay, so inflammation either alone or combined with high LDL is clearly linked to worse outcomes. Now, the million-dollar question. What happened to the isolated residual cholesterol risk group in this adjusted analysis?
This is probably the most provocative finding of the study. After adjusting for all those confounders, there was no independent association between having isolated residual cholesterol risk, LDL 70H, hs-CRP2, and the risk of MAE at 1 year.
No association at all.
Essentially none. The adjusted hazard ratio was 1.01 and the p-value was 0.920, meaning it was nowhere near statistically significant.
So in this specific post-PCI, statin-treated population, having an LDL above 70 if your inflammation was low, didn't seem to independently increase your risk of death, MI, or stroke within the first year, once other factors were considered.
That's what this analysis suggests, yes.
Yeah.
And the overall trend across the four groups, from no risk to cholesterol risk to combined risk to inflammatory risk, showing the highest adjusted risk, was highly statistically significant. It really underscores the apparent importance of the inflammatory pathway here.
That's a really powerful message. It shifts the focus quite dramatically, doesn't it, away from just LDL numbers in this context.
It certainly seems to, at least for predicting events in that first year post-PCI.
Did they look at any other outcomes, maybe break down the MBC components or look at repeat procedures?
Yes, they did. They looked at an expanded ME definition, ME plus one, which also included target lesion revascularization, basically needing another procedure on the same artery.
Okay.
And again, isolated residual inflammatory risk was independently associated with a higher risk of this broader MC plus endpoint, about a 36% increased risk.
So the pattern holds for repeat procedures too. What about the individual components of MB, like death?
That was particularly striking. When they looked specifically at all-cause mortality, the isolated residual inflammatory risk group had a huge increase in risk, an adjusted hazard ratio of 2.59, so more than 2.5 times the risk of dying compared to the no residual risk group.
Wow, that's a strong signal for mortality.
It really is. The combined risk group also had a significantly higher risk of death, about 70% higher. But, again,
Let me guess. The isolated cholesterol risk group.
no significant increase in mortality. Adjusted hazard ratio was 0.98. No link there.
So inflammation seems particularly tied to the risk of death in this first year.
That seems to be a key driver of the overall MPE finding. When they looked at spontaneous MI specifically, only the combined risk group showed a significant association.
Okay, so maybe cholesterol plus inflammation is needed for that specific outcome.
Possibly. And for stroke, or needing any repeat revascularization on any vessel, not just the target one, they found no significant independent association for the isolated cholesterol risk group.
The story seems pretty consistent across different endpoints then. Inflammation is the recurring theme.
It really is.
And did this hold true if you slice the data differently? Like, did it matter if patients were older or had diabetes?
They did look into that with sensitivity analyses. They checked if the effect of residual inflammatory risk was consistent across various subgroups, different ages, men versus women, patients with or without diabetes, with or without CKD, different baseline lipid levels. And largely, yes. The negative impact of having that residual inflammation seemed pretty consistent across these different types of patients. That adds confidence to the main findings. It suggests it's a robust effect.
Okay, so let's try and pull this all together. If you're a cardiologist listening to this, what's the main clinical takeaway message from this Mount Sinai study?
I think the core message is this. For patients who've had a PCI, not for an acute MI, and who are on statin therapy,
Right.
it looks like residual inflammation, which we can measure with hs-CRP specifically, a level of 2 milligl or more, is a more potent predictor of major adverse cardiovascular events within that first year than having residual LDL cholesterol elevation above 70 milligdl.
So inflammation trumps cholesterol in predicting risk in this setting, at least in the short term.
That's what the data points towards. It really makes you think about that concept of residual risk, doesn't it?
Absolutely. We've focused so intensely on driving LDL down, down, down.
And that's still crucial. But this study fits with other observations. Remember the big 4-year trial with PCSK9 inhibitors. Even when they got LDL levels incredibly low, patients still had cardiovascular events.
Right. There was still risk remaining.
Exactly. It suggested something else was contributing. And other analyses, pooling data from trials like Prominent, Reduce It, Strength, have also suggested that hs-CRP might actually be a stronger predictor of future events than LDL-C in statin-treated patients generally.
So this isn't totally out of the blue, but this study really focuses it on the post-PCI population.
Yes, that's the novelty here. It's looking specifically at this common high-risk group right after their intervention.
Now, we need to be super clear here. This absolutely does not mean statins aren't important, correct?
Oh, absolutely not. Let's be crystal clear on that. Every single patient in this study was on a statin. Statins are the foundation. They lower LDL, which is critically important long-term, and they also have some anti-inflammatory effects themselves.
Okay, good. So lipid lowering remains essential.
Essential. But what this study suggests is that in addition to statins, we might need to pay more attention to that lingering inflammatory risk. If the hs-CRP is still high despite the statin, that patient seems to be in trouble.
Which naturally leads to the question of, well, can we treat the inflammation directly? The study mentioned trials like Colcott, Lodoco-2, Cantos.
Right. Those trials explored anti-inflammatory drugs. Colcott and Lodoco-2 looked at low-dose colchicine, and Cantus looked at canakinumab, an antibody targeting interleukin-1 beta.
And they showed some benefit.
They did, yeah. They showed reductions in certain cardiovascular events in specific groups, usually patients with established heart disease, sometimes selected for having elevated hs-CRP like in Cantos. So it proves the concept that targeting inflammation can work.
But are those results directly applicable here? Were the patient groups and outcomes the same?
Not exactly. As the authors of this current study point out, hs-CRP wasn't systematically measured or used for selection in Colcott and Lodoco-2. And the types of events reduced in those trials, while important, didn't necessarily show the same strong link with mortality that this current study found driven by inflammation.
So the link between inflammation and specifically dying within a year seems particularly strong in this post-PCI analysis, maybe stronger than seen in those anti-inflammatory trials.
That seems to be what the authors are suggesting, yes. It might be a slightly different picture. They also mentioned there's ongoing research into newer anti-inflammatory agents, like ones targeting interleukin-6, which might give us more tailored options down the road.
So it sounds like maybe, just maybe, measuring hs-CRP routinely after PCI in these patients could help us identify who's at highest risk from inflammation.
That's definitely a potential implication.
And maybe those are the patients who could benefit most from adding an anti-inflammatory therapy in the future once we have the right agents and strategies, on top of their statin, of course.
That's certainly the direction this research points. hs-CRP could become a key biomarker, not just LDL, for guiding risk stratification and potentially therapy selection after PCI.
Okay. Now, we should always talk about limitations. No study is perfect. What did the researchers acknowledge were the potential weaknesses here?
They were upfront about several things. First, it's a single-center study from Mount Sinai, so you always wonder if the results would be exactly the same in a different hospital system or country.
Sure, generalizability.
Right. They also didn't have data on the intensity of the statin therapy. Were patients on high-dose or low-dose statins? And they didn't have data on medication adherence, which can be a big factor.
True, we don't know how well people were actually taking their meds.
Another point is the exclusion of patients with hs-CRP over 10 milligl. While done for good reasons, it means the findings might not apply to patients with very high levels of inflammation. And like any observational retrospective study, there's always the possibility of unmeasured confounders, other factors influencing the results that they couldn't account for.
Always a possibility when you're looking back at data.
Yep. They also noted some patients were lost to follow-up early on. The follow-up was only for 1 year, which is relatively short-term.
Right, what happens at year 2, 3, 5?
We don't know from this study. Also, if patients had events treated at other hospitals, those might not have been captured perfectly, and they didn't have specific causes of death, just all-cause mortality. Plus, no follow-up hs-CRP or LDL levels to see how things changed over time.
So, quite a few caveats, as always in clinical research. But despite those limitations, the core finding seems pretty robust, doesn't it?
I think so. It's a large cohort, well analyzed, and the signal for inflammation being a key driver of risk in that first year post-PCI, independent of LDL in this context, is quite strong.
It really reinforces this idea that atherosclerosis is not just a plumbing problem, it's an inflammatory disease.
Exactly. Cholesterol deposition is crucial, but the inflammatory response to it seems to be a major determinant of whether plaques become unstable and cause events.
Well, this has been incredibly insightful. Thank you for breaking down this complex but really important study.
My pleasure. It's definitely food for thought.
So for everyone listening, this has been our deep dive into that interplay between cholesterol and inflammation after PCI in patients already on statins. For more discussions like this on the cutting edge of cardiology research,
make sure you subscribe to Evidence-Based Cardiology Talks. We're on Spotify, YouTube, wherever you get your podcasts.
Stay informed, stay curious.
Yeah, absolutely.
And we'll leave you with this final thought to ponder. Given these findings that really spotlight residual inflammation as a major risk driver after PCI, maybe even more so than residual cholesterol in first year, how should this change our day-to-day management? Should routine hs-CRP testing become standard practice post-PCI? And what kind of research do they need next to figure out exactly how and when to target that inflammation effectively alongside our essential lipid-lowering strategies?